Hi, welcome to Guidelines for Mass Casualty Triage, presented by Dayton MMRS and the Greater Miami Valley EMS Council. Today we'll have Dr. Jim Brown, who's chair of the Department of Emergency Medicine with the Wright State University Boonshaw School of Medicine, and me, David Gerstner, the MMRS Program Manager with Dayton Fire Department. And we'll be going over some of the new materials in the Greater Miami Valley EMS Council Standing Orders for 2013. Our objectives for today: at the end of this presentation, you should be able to discuss the differences between daily and disaster triage, understand the SALT mass casualty triage method, and be prepared for your standing orders skill evaluation. I think everyone by now knows that triage is a term that comes from a French verb meaning to sort, and the concept is very simple. In a mass casualty incident or a larger disaster, we need to be able to assign priorities when our resources are limited. Unfortunately, in a very large incident, somebody has to go last, and we don't want the person with the greatest need to be the one to go last. At the same time, we don't want someone who simply could not benefit from medical intervention to go ahead of those who would get benefit. In short, we're trying to do the greatest good for the greatest number in the shortest period of time. The concept of triage has been around for a long time. Many people say that it started with Napoleon's surgeon-in-chief, who was Dominique Jean Larrey, in Napoleon's army, and he started to sort out and therefore to triage victims who were wartime casualties. 200 years later, this simple concept has become much more complicated. We have dozens of systems, numerous types of triage labels and tools, including tags and ribbons and many other things, and there is simply no standardized system for mass casualty care in the United States. In a disaster, in a mass casualty incident, there are many, many problems involved. The scene response is, by definition, chaotic. There are pressures from many sources. Bystanders may be offering assistance, which is inappropriate. Bystanders may actively interfere, and certainly you'll receive pressures from the bystanders. Why haven't these patients been removed yet? Why is he still sitting there? Why aren't you taking care of this victim? There can also be secondary threats. Some of those can be intentional. Some of those may be accidental and related to what caused the incident. When it becomes a multi-jurisdictional response, those problems can get even larger because the people that you've called to help may not follow the same procedures that you do. We are trying to solve that problem by having a standardized system to use throughout our region. And of course, when we have both civilian and military responders involved, then the complications become even greater. There are lots of things that are unique about triage in a mass casualty incident, including the sheer volume of patients that you're dealing with. The photo here is from the 2010 Haiti earthquake. 316,000 people lost their lives in that incident, and another 300,000 were injured. Certainly, that defines limitations on our infrastructure to provide care for these people. We may not have providers, we may not have enough victims, we may not have enough equipment, we may not have enough transport capabilities, meaning enough ambulances, and certainly one of the things that EMS must keep in mind is that we may have serious limitations on hospital resources, and we'll talk more about that in a little while. Furthermore, as we've already mentioned, there can be serious hazards at the scene, including threats to providers, again, intentional or accidental, problems with contamination and the need for decontamination, and even things like secondary devices or unsafe structures. When we do exercises, it looks like this. All neat and tidy and everything's arranged just exactly the way it looks in the books. Unfortunately, real life tends to be messy. When you're at an incident such as the Virginia Tech shootings, this becomes chaotic. It gets even worse in larger incidents, such as this earthquake that occurred in Pakistan. And you can see the huge structural damage that's taken place here, and just imagine how much less organized the response is and all the problems that you would deal with in an incident like this. Finally, one last incident that is the very epitome of a problem situation. This is referred to as the Great Boston Molasses Disaster of 1919, and a huge storage tank of molasses collapsed and flooded an area with sticky molasses. 21 people died, 150 were injured, and trying to sort through and deal with triage in a scenario like this would be challenging even today. A while back, the Centers for Disease Control, the CDC, began to look at triage systems around the United States and sponsored a project to, among other things, try to develop a national standard for mass casualty triage. They assembled a list of all the triage methods in use not only in the United States but around the world, looked at published research data, and looked at practical experience and compared all the features of the various systems. Their findings were that there was no one triage system that was truly supported by the evidence as one that would be both the best and be practical for use in a mass casualty. Among the systems reviewed by the Centers for Disease Control were systems called CareFlight, the French Plan or ORSEC, Glasgow Coma Scale, the Homebush Plan, the Italian Plan, Jumpstart and START that are used in the United States extensively, the MASS triage system, the NATO triage system, a proprietary system developed by a man named Sacco, and a system called the Triage Sieve. They compared the various features of all of these systems and again decided that no one system was really the one we wanted. And so they developed the SALT triage guideline, SALT standing for Sort, Assess, Life-Saving Interventions, Treatment, and Transport. Developed the SALT guideline to try to use the best of all of the different systems. This was based on the best evidence that's available in the medical literature and in practical experience of numerous experts who were assembled by CDC. Since then, the concept of SALT has been endorsed by the American College of Emergency Physicians, the American College of Surgeons Committee on Trauma, the American Trauma Society, the National Association of EMS Physicians, the National Disaster Life Support Education Consortium, the State and Territorial Injury Prevention Directors Association, and the Federal Interagency Committee on EMS, among many others. So, some people have asked, why are we changing in this region from START triage? And one of the best reasons is simply that the stated goal of START is to triage each victim within 60 seconds. In a large incident, 60 seconds per patient is simply far too slow. Furthermore, the physiologic criteria proposed in START, particularly the respiratory rates, have never been validated as an appropriate way to categorize victims from a mass casualty incident. Real-world use of START has been very limited, and there's even literature to suggest that EMS personnel who were trained in START have failed to use it during a mass casualty incident, partly because they simply recognized that they didn't have the time to go through the entire START process. More than that, using START can actually delay LSIs, or life-saving interventions. If you spend 60 seconds per patient and have a lot of patients to go through, The last ones you reach may no longer need life-saving interventions because they may simply have already expired. Finally, another problem with START is that it lacks an expectant category, and we'll be talking much more in this presentation about the benefits of the expectant category. So the consensus findings from CDC were that a system needs to include a global sorting process. It needs to focus on life-saving interventions. They found that the best medical categorization was based on mental status and systolic blood pressure. Unfortunately, systolic blood pressure slows things down, so that is not part of the SALT process. They found that any triage system to be practical in a disaster needs to be simple, it needs to be quick, it needs to be cheap, and should use the NATO triage categories that we really have been familiar with for some time for the most part, plus a category for patients who simply will no longer benefit because they are dead and beyond the possibility of recovery. Sort, assess, life-saving interventions, treatment, and transport. That's SALT triage. It's simple, it's easy to remember, it groups large numbers of patients very quickly, and even more than that, it applies truly life-saving interventions very early on in the process. It can be used whenever the number of patients that you're dealing with exceeds your resources, either for treatment or for transport. It uses the exact same process for both adults and pediatric patients when we're categorizing those patients. The one difference is that we have one additional life-saving intervention, or LSI, that you can use for pediatric patients. The system was recommended by the Dayton MMRS Triage Committee and approved unanimously by both the Greater Miami Valley EMS Council Standing Orders Committee and the Region 2 Regional Physicians Advisory Board. So general principles before we move into the specifics of SALT. First of all, obviously, you'll want to move as quickly as possible. But that means as soon as you can, start moving the red patients out. Patients who truly meet the category for red need to be removed to the hospital as quickly as we can. At the same time, you should not neglect the processes of managing this incident. That means following triage. That means allocation of patients to hospitals, which we'll talk more about in a moment. That means following command processes. We recommend using triage ribbons initially at the site where you find the patients. Then apply tags later on. Tags are probably most easily applied at the casualty care collection point, the CCP, or the treatment area. However, if you have red patients who are going directly from the site into vehicles to be removed to the hospitals, then apply the triage tags in the transport area. Remember, too, something that may seem counterintuitive. Over-triage can be as harmful as under-triage. Now, when we're dealing with one trauma patient at a time, we recommend over-triaging as necessary. But when you've got multiple patients, if everyone is categorized as red, then we're left with we haven't sorted them at all. And neither EMS nor the hospitals can provide the best care. So that's why we say over-triage can be just as dangerous as under-triage. We want to mention the importance in an MCI of the transport officer or the transport group or transport unit. Transport is crucial to the overall success of your efforts to resolve the mass casualty incident. Transport is responsible for ensuring that secondary triage has in fact taken place prior to transport and is responsible for making sure that each patient leaves the scene with a triage tag. Transport is responsible for working together with the treatment group to assign priorities and decide, quite simply, who leaves the scene first. More than that, transport's responsible for hospital allocation. One of the things that EMS has failed at time after time after time in a mass casualty incident is adequately spreading the load. It doesn't help anyone if you simply relocate the disaster to the hospital. If we take a huge number of victims to one location, that hospital is unable to provide optimal care. Use non-trauma centers. Use more distant hospitals. Use whatever resources are needed so that you spread that load. That will result in the victims getting better care. Finally, communications are always a problem in disasters. If you've got a major incident, consider use of the regional hospital notification system that's covered in your standing orders to notify all of the hospitals in the region. Even the ones who aren't receiving patients will appreciate being aware of a major incident. Finally, before we get into the SALT process itself, we want to mention that in addition to the categories of SALT, we have added an additional color into our standing orders. The orange ribbons are used to indicate contaminated patients. The ribbons should be removed once the patients are deconned, but remember, it is our responsibility as EMS to perform primary decon prior to transport, and even though they've been decontaminated, notify the hospitals that those patients were contaminated and with what. And with that, we'll now move to Dr. Brown, who will go through the process of SALT.
So this slide looks a little scary initially, but we're going to take it in biteable chunks, and I think once we work our way through it, it won't be quite as daunting. So this is the big overview picture of the SALT process. Step one is global sorting. That's this first area where it says step one, and it's walk, wave, and then still are the three categories you're looking for. So the first thing that you should do is, preferably by using a loudspeaker, say, everyone who can hear me, please move over to this designated area and we will help you. Everybody who gets up and moves, then by definition has certain physiologic criteria. They're able to hear you. They're able to have enough mental status to process what's going on, and they have enough of a blood pressure to get up and move over to the designated area. By definition, those patients, with some exceptions, are going to be in pretty good shape. This is a way to get all your ambulatory patients out of the way and to basically thin the herd and do your preliminary global sorting. These are generally the last patients you would want to do individual assessment on because they've already sorted themselves out with your first step. The second step is to say, if you need help, wave your arm or move your leg and we'll be there to help you in a few minutes. Again, patients have to be able to hear what's going on, be able to mentally process the command, and at least have enough of a blood pressure or whatever to wave their arm or move their leg. This tells you there may be non-ambulatory patients, but are still able to follow commands and make some purposeful movement. These are your second priority for assessment, but these patients aren't probably the sickest patients. In some cases, they may have a sprained ankle, a broken leg, something that keeps them from getting up and walking, but aren't as seriously injured. Now you have people who are basically, have already walked out of the way, some people who have waved and have identified themselves as in at least somewhat better shape, and your last group are the patients who are still, or those who have an obvious life threat. You still have some problems with the global sorting issues. Obviously, a mother could pick up an unconscious child and carry them over in step one. So you may still have some seriously injured patients in that group. You may also have, which frequently happens particularly with elderly patients, a husband or a wife who refuses to leave their spouse's side, period. So you may have some seriously injured people, you may have some not so seriously injured people still on the scene, and patients who are having a heart attack could still get up and walk over to the secondary triage area, and that's another issue you have to address. So ultimately, you still have to assess each individual person one at a time, but this lets you set some priorities. Your next step is to go to all the non-ambulatory patients, the patients who didn't move, go right to where they are and apply the 4 life-saving interventions if they need them. The life-saving interventions, however, can only be done if they're within your scope of practice. As you're going to see later, needle decompression of a tension pneumothorax is in the life-saving interventions. Obviously, EMT basics are not authorized to do that skill. Also, you may not have the appropriate equipment available. You may not have a whole handful of needles to do needle decompressions. It is important that you keep moving and that you don't return to your medic to just get a piece of equipment, etc. Your goal is to move through these patients as quickly as possible and at the same time quickly identifying or quickly providing life-saving interventions. All right, so now we've moved past step 1, the global sort, and into step 2. So that's this part right here, life-saving interventions. Let's talk about these for just a second. So the first thing is to control major hemorrhage. That may very well involve using a tourniquet. So if you have tourniquets available, this is likely where you're going to employ them. You have a person with a lost arm or a lost leg, and you may be able to apply a tourniquet and control major hemorrhage very quickly. If you're able to quickly apply a pressure dressing to hemorrhage, that may also be helpful. You may be able to use bystanders. You may be able to use some of your patients who are in sort of your global sort category 2, somebody with, let's say, a sprained ankle, they may still be able to hold pressure on a major hemorrhage on a patient nearby. If the patient's not breathing, you should open their airway. If an adult is not breathing after you open their airway, you don't need to provide any further intervention. For a child, you can consider giving 2 rescue breaths. This is not required. It was somewhat controversial during the development of SALT, but when it was all said and done, they decided to give people the opportunity to intervene with children by giving 2 rescue breaths. Next, if the patient has evidence of a tension pneumothorax, needle decompression of the tension pneumothorax should be done. And finally, if there's evidence of a chemical incident where you would need to use auto-injectors, antidotes, and you have those available, using auto-injector antidotes is also in the life-saving interventions. After that, you would move on to individual assessment. So we've done our life-saving interventions, and now we're going to move on to this category. While this looks fairly complicated, when it's all said and done, it really is pretty simple, which was the goal of SALT triage. So there are 5 categories: immediate, delayed, minimal, expectant, and dead. ID med is your mnemonic for this. Red for intermediate, yellow for delayed, green for minimal, gray for expectant, and either black or zebra striped for dead. We're going to attempt to get zebra striped ribbons and tags because we recognize that at night, seeing a black tag is going to be pretty difficult. The dead category, patients who are not breathing after you open their airway, or in kids, after you've given 2 rescue breaths and they're still not breathing, those patients get tagged as dead. We want to tag those patients to be sure that they don't get re-triaged, so someone knows that those patients have already been identified. Ideally, you would not want to move these patients because you don't want to destroy evidence. However, if you have to move a dead patient to get access to live patients, that obviously supersedes the concern about evidence. If the patient's breathing, you move on to your next assessment. Next, you want to assess for serious injuries. What you're looking for are immediate life-saving problems that have a high potential for survival. Things like a tension pneumothorax or an exposure to nerve agent. Those patients are obviously immediate. You would use your life-saving interventions if you have them available, and then triage those patients as red. Patients who are immediate, you would answer no to any of these questions. So, is the patient able to follow commands or make purposeful movement? So, if you do something like show me two fingers, move your hand, and squeeze my fingers, and they're unable to do so, then that person would be an immediate. Next, you'd want to feel for a peripheral pulse. This is basically a surrogate for looking for elevated blood pressure. A patient with a peripheral pulse is not as sick as a patient whose blood pressure is so low that while they're still breathing, they're not able to maintain enough of a blood pressure to have a peripheral pulse. So just feel for a radial pulse or a brachial pulse, see if you've got one, and then move on to the next step. Is the patient in respiratory distress? If they're breathing normally, they may not be an immediate, but if they're having some respiratory distress, they're also immediate. And are you able to control the hemorrhage? So while they may have an arm or leg blown off, if you can apply a tourniquet and control their hemorrhage, they're no longer immediate. If you can't control their hemorrhage, those patients will move on to an immediate category. And the last assessment is a bit of a gestalt, but it is, are they likely to survive given the resources that you have available? And we're going to talk about that specifically here in just a second. So, our mnemonic for these assessment questions are CRACK. Can they follow commands? They have no respiratory distress, no uncontrolled arterial bleeding, and peripheral pulses are present. If they answer bad to any of these categories, they're either triaged as red or gray. Bad being defined as they can't follow commands, they have respiratory distress, you cannot control their bleeding, and they don't have a peripheral pulse. Then they're either going to be an immediate patient or an expectant patient based on whether or not you think they will survive given the resources you have available. The expectant category are patients who would be otherwise triaged as immediate, but you think are not likely to survive given the available resources that you have on hand. This is a new category in our system. This has been somewhat controversial over time, but those who developed this protocol and approved it feel very strongly that the expectant category is important. This is a way to still preserve resources for patients by taking care of people who are more likely to survive. So patients with very serious injuries but have poor survivability no matter what, even in the best of circumstances, we're going to triage as expectant. Examples of this would be a person with a 90% body surface area burn or the multi-trauma patient that has brain matter showing. A patient with a gunshot wound to the head that has brain matter exposed is not likely to survive no matter what we do for them. We should triage them as expectant because we need to get the immediate patients to the hospital first. That doesn't mean these patients are dead. It means these patients are not likely to survive. Ultimately, we may wind up transporting these patients because they may be there may be palliative care that they need, or they may actually be organ donors. But we should delay treatment and transport of these patients until we have better resources and better able to transport patients. If we have delays in the field and we have adequate resources in the field, we may consider some palliative measures for these patients, things like pain medications, if we're able to have the time and the folks to handle that as the disaster unfolds. Our next category is the delayed category. Now, you look at that, and most of us would go, well, that looks pretty serious. That's a bit of a frightening thing here. You know, actually, the foot should normally be running straight up this way, but obviously this is a serious fracture dislocation. However, this patient's going to do fine if their care is delayed for a period of time, particularly against patients who don't have a blood pressure or in respiratory distress. So things like long bone fractures, a 40% body surface area exposure to mustard gas, these patients obviously need treatment. This patient definitely needs decontamination before they're transported. But at the same time, they'll do well if they wait for some time, and there may be other priorities that intervene. So the delayed category means that you would answer yes to all of these categories, and these injuries are not what you would call minor injuries. So we sort of define as not bad because of the way these are phrased, but if the patient's able to follow commands and or make purposeful movements, has a palpable peripheral pulse, is not in respiratory distress, and you can control their hemorrhage, but they still have some serious injury like a fracture or a serious chemical exposure, these are the patients that would be tagged as yellow and they're delayed. On secondary triage, you may assess people with higher priorities for transport than others. So within the delayed category, and also even within the immediate category, if you have 10 patients who are delayed and you only have 2 ambulances, you can't remove all those patients at once. You need to set priorities. So a patient who looks like they're having an MI may get transported first over that patient with that fracture dislocation of the ankle, but who still has a pulse in that foot. Patients with a tourniquet on, where you've controlled the bleeding, versus patients who have a laceration that the bleeding is easily controlled, that patient may have priority even within the delayed category. So we have to look at secondary triage. Lastly comes the minimal category. In this category, you have no badness, if you will. You answer yes to all these questions again. Follows commands, has a good peripheral pulse, not in any respiratory distress, and their hemorrhage is controlled, and their injuries are minor. These are patients with cuts and scrapes, maybe your psychological patients, etc. So abrasions, minor lacerations, a nerve agent exposure with just a runny nose. This patient may need decon, but they're probably not going to need transport immediately. These are your green patients, your minimal patients. Well, again, to reiterate, what we'd like to do is as you start moving through triage, you start with the triage rivets. At either the treatment area or at the casualty collection point or point of transport, that's where we would add the triage tags. If available, we want to use the right wrist for both the ribbon and the tag, and we leave both on. But our goal is to have the right wrist if you can get to the right wrist. After the patients are categorized, after you've done your initial categorization, remember that this prioritization process is a very dynamic one. Patients' conditions may change. Patients who were in the delayed category may worsen. That controlled bleeding may become uncontrolled, and the patient may move to a immediate category. Then again, some patients may have been over-triaged. Their injuries don't look quite so bad when you get down to a secondary assessment, and you may actually change them from an immediate to a delayed patient. So this is a chance to correct some misses, reassess patients based on changing conditions, and also look at your resources. You may figure out that in your initial sort that you had 20 patients who were immediate. As you go through, you may realize that given the resources you have, you're not going to get all those patients out of here within the next 10 or 15 minutes, and you may have to realign your priorities depending on what you have. Once you've gotten all the immediate patients out, then you want to reassess all the expectant, delayed, and minimal patients and realize that some patients have gotten better, some patients may not have gotten better, and you need to resort their categories to decide who gets to go next. In general, we would transport immediate patients first, then delayed, and then minimal patients. We would transport the expectant patients when we have resources available. Expectant patients may go ahead of minimal depending on how minimal the minimal patients are. At the same time, you may be able to put a minimal patient or a delayed patient in the cab of your medic with a couple of immediates in the back if their bleeding's controlled, etc., just to be able to move that patient on and out of your scene. So mixing patients may happen. It's not absolutely forbidden, but obviously our priority is immediate, then delayed, and then minimal as a sort of global guideline. All right, we're going to go through an example so you can kind of see how the SALT triage piece is applied. So you and your partner in a single medic are the first responders to a multiple gunshot wound situation at a local sporting event. There are 10 casualties. What are the issues that you need to worry about? And the paradigm we're going to use is the disaster paradigm. So the first thing we look at is detection. Well, you realize you got 10 patients. Already you realize you've got a multi-casualty event, and the needs are greater than the resources. Pretty good chance you and your partner are not handling a 10-patient gunshot wound incident. Incident command. Who's the incident commander? Well, if you and your partner are the first guys on the scene, well, that would be either you or your partner to start. Obviously, that's going to shift as other personnel show up. Scene safety is always one of our primary concerns, and we need to be concerned, is there still an active shooter? Are there secondary devices that have been left behind? Have the police been able to secure the scene or render the scene safe for us to enter? We need to assess any hazards. Obviously, the hazards are penetrating trauma to these patients. There may be additional hazards, as we talked about just before. Support. Obviously, you're going to need law enforcement. You're going to need backup medics. You're going to need to advise medical control. Your trauma center needs to be spun up. You may need to use community hospitals for some of the less seriously injured, and you're going to need some supplies, maybe some tourniquets, etc., are all things that you're going to need. Triage, transport, and treatment are what we're going to get into, and then we'll talk about the recovery phase at the end. So, the first thing we're going to do is our global sort. So what are you going to do? You're going to say, hey, anybody who can hear me, get up and walk over here to this space over here. Immediately, 2 of your patients get up and walk. Now you're down to 8. All right, anybody else who can hear me, can you wave your hand, and we'll get to you here in just a second. 3 patients are able to do that, but 1 you notice has an obvious severe hemorrhage. And lastly, that leaves you 5 patients who aren't moving. Those are going to be your first priority, these patients your second priority, and you're going to get to these 2 folks last. First patient you come to is one of the patients that's still. He's a young male with a gunshot wound to the left chest. He has a radial pulse present and is in severe respiratory distress. How would you triage this patient? That's correct. He's an immediate. Your next patient's an 8-year-old girl with a through-through gunshot wound to the head with visible brain matter, a respiratory rate of 4, and a positive radial pulse. Yeah, unfortunately, she's expectant, and that's because she has an injury that is not likely to be survivable given your current resources. Your third patient's a 50-year-old guy with gunshot wounds to the abdomen, chest, and extremity who is not moving and not breathing. Yeah, he's dead. You need to tag him as black and continue to move on. You might want to open his airway, but once you open his airway and he doesn't breathe, he needs to be tagged as dead. Your next patient's a middle-aged lady with a gunshot wound to the neck with gurgling respirations, marked respiratory distress, and has a radial pulse. How would you triage her? That's right, she's immediate. And lastly, of your still patients, you got a 16-year-old kid with a gunshot wound to the right chest who's not breathing. You open his airway, he continues to not breathe, and he's going to be triaged as dead. This lady up here, depending on her respiratory distress, you may decide that you need to needle decompress her chest. That would be your life-saving intervention up here. All right, so we've triaged our first 5 patients, and we have 2 immediate, 1 expectant, and 2 dead. Your next are your 3 patients who are waving. Your first one is a 15-year-old young male who has a gunshot wound to the right extremity who's actively bleeding. After you apply a tourniquet, how would you triage him? If you're able to control his bleeding, he would be delayed. You tag him as yellow. 65-year-old guy with severe chest pain, diaphoretic, obvious respiratory distress, but doesn't have any holes in him. This guy's an immediate because he looks like he's having an MI. In multiple gunshot wound situations historically, there have been patients who've had MIs during the incident that don't have any penetrating trauma, but wind up having an MI during the incident. Your last one's a young girl, 22 years old, gunshot wound to the right leg, good pulses, no active bleeding. How are you going to tag her? That's right, she's probably delayed. You might consider even making her minimal depending on how many delayed patients you have. So now you have 3 immediate, 2 delayed, 2 dead, and 1 expectant. Lastly, you got 2 patients who walked away. First one's a 29-year-old guy with a superficial gunshot wound to the skin of his upper arm. He's basically got a grazed wound, and you would triage him as minimal, green. Your next one's a 37-year-old guy. He's got a gunshot wound to his left hand, but he's got exposed muscle, tendon, and bone fragments. He has peripheral pulses present, and his bleeding is controlled. Yeah, he's probably a yellow. So you now have 3 immediate, 3 delayed, 1 minimal, 1 expectant, and 2 dead for your 10 patients. Another ambulance arrives. They show up and take 2 of your immediates off your hand. Your partner is taking care of the other immediate patient. What are you going to do next? Yeah, you need to go back and start reassessing these patients, maybe provide some secondary treatment. So, this last couple of slides, we're just going to talk briefly about a study that was done looking at salt triage, because we've now been through this process, and how easy is it? In a study that was done by a couple of colleagues of mine, Richard Schwartz, Brooke Lerner, Phil Kuhl, and Ron Perallo, who I've worked with all in the past, 43 trainees participated in a course. In that group, it was kind of a diverse group, 16 physicians, 10 nurses, 5 EMTs, 5 PAs, 3 pharmacists, and 4 other folks. Prior to the drill, they did sort of a little pre-test, and about a third of the people said they didn't really feel confident using salt triage. After the drill, everybody felt confident that they could apply salt triage. A third of folks said they felt the same way they did before, but 76% of people felt more confident in their ability to do this, and nobody said they felt less confident after a drill in their ability to apply salt. Before the drill, more than half of people thought that salt was easier than whatever they were using in their system. After the drill, 85% of those folks didn't change how they felt about it. 13% thought it was easier, and only 2%, which was 1 person, thought it was harder than they thought it was. So bottom line, providers receiving a 30-minute training session, very similar to what you've had here in salt triage, felt good about using it. They also felt salt was similar or easier to use than their current triage protocol. And then they applied it during a simulated mass casualty incident, and that seemed to improve provider confidence. You've had the same training, and hopefully you feel that this is a much better system than what we've had in place, and it's easy to use. So here's just to go back over things: salt triage, global sorting, and then an individual assessment. First, using your 4 life-saving interventions, using your CRAP mnemonic, and finally assigning your triage categories, and then transporting patients.
We're going to try to set up a frequently asked questions file on a website for you, so that as you develop questions or you're presenting this in a group and have some questions, we'll have a way for you to submit those. We hope this has been helpful. You should now be ready to go through the skills sheet and complete your standing orders process to be checked off in salt. Hopefully we won't have to use it in this area, but if we ever need to, we'll be more prepared than we ever have been. Thank you very much for sitting in on this presentation. Good luck to everyone.